most of us who have been old enough, they know each other, so there is no need for such a. I congratulate the team at Om because Om is the very sacred syllable and symbol of spiritual guidance. And since taking it to version 10 itself is an achievement, and doing a focused meeting on one topic so intense is really worth congratulating. On behalf of the ABSI and the HCG Asta Cancer Center, I welcome you all. I have been, whenever Jasprit Bumrah needs a change of ends, they usually throw the ball to the person standing at second or third slip. That why don't you bowl one over so that the regular plastic surgeons can come in and bowl. So we had Dhanushya Goyal, 3,000 cases, and following me is another great bowler, Dushyant Jaiswal, 5,000 microvascular surgeons. So then they said, so this is a short video on Grisotti flap. When nearly 3 decades ago, when we joined MCH, the agenda in surgical oncology was that retroareolar tumors otherwise were considered to be contraindications for doing breast conservation surgery, and many of these cases we didn't do. I was with Dushyant last week in a meeting in Calcutta where we discussed that probably doing Grisotti flap in this conventional way is no longer one of the major options. We would rather to do it like a inferior based pedicle flap rather than doing it in the conventional way in which we have been doing it for so long. So this is a lady who has a round retroareolar tumor right near the nipple areola complex, and I am sure it's going to be very difficult to preserve that part. So this is the skin island. It's a dermograndular flap. These are the parts that are going to be de-epithelialized. Ultimately, all flaps will have some perforator on which they are going to be braced. So first the tumor is being excised and the island is being marked, and so is the dermograndular flap and the incision, so that you can de-epithelialize while still the tumor is in situ. We'll quickly go over because they have given me 2 flaps. So that is the dermoglandular flap completely de-epithelialized. At that time we were doing it with a blue dye. We sometimes now do with a blue dye and an ICG dye. Here the tumor is being completely excised with the overlying nipple areola complex. The tumor is palpated at all times, and we aim to achieve good gross margins of about 1 centimeter all around. Some of the microvascular surgeons might not be too keen on finding out how tumors are excised. Because the tumor was very close to the nipple areola complex, we did not go right down to the pectoral fascia. We palpate the tumor anteroposterior, medial, lateral, superior, inferior. We take sutures, short superior, long lateral, clip the margin, sometimes send it for frozen section, sometimes for specimen mammography if we suspect that there is microcalcification at any of the places. So most of the breast flap, the volume of the flap is on the lateral side, so we mobilize it laterally. Most of the blood supply we take from the medial side, and here it is deepened right down. We have to be careful not to wedge it too close to the pedicle, and then the flap is raised at the level of the pectoral fascia. You can, if the flap doesn't reach into the defect, you can mobilize slightly onto the medial side, just enough to, so that it sits comfortably in the space which we have created. Clips are placed at the margins and base of resection, and this is the closure that we achieve. And this is the post-operative result of the same patient. This is the other case that I was talking about, where we have done for a left-sided tumor a similar procedure, and the flap has been sutured into position, and early post-operative results for the same patient. Here the tumor was not exactly at the nipple areola complex, it was much below that. So this is a more laterally based similar flap which we have devised, where even if the defect is here, even if there is skin involvement, you have to excise the overlying tumor. You can draw a similar island. Of course, you need a size B, size D cup shape breast in order to be able to um, get enough volume. Here you can see the tumor, the nipple area complex is still intact, and the tumor has been excised. And we use all the lateral tissue. Ultimately, it is the lateral tissue that is going to provide the defect, help cover the defect, whether it is the skin and the glandular tissue. Thank you. So I will now move on to my second video. Back. So this is a lady who has a tumor located in the lower outer quadrant. This ideally it's very useful for tumors located in the upper outer quadrant, but at a very initial oncoplastic procedure, I think if it provides access to most of the areas, the size of the tumor is small, you do not want to place the incision directly over the tumor, then probably it works well. It's a double track incision, so that you can excise the intervening nipple areal, the skin, and gain access to the various quadrants of the breast. This part is completely deepithelized. This helps us preserve the blood supply of the nipple areola complex. Flaps are usually raised at the level of the mastectomy scar because the tumor is quite away from the nipple areola complex. Now we have come to the region of the tumor where the tumor is excised in an elliptical pattern so that it becomes easier for us to close the defect in that particular fashion. Again, the tumor is being excised, short stitch superior, long lateral. In this case, the tumor was deeply situated, and I think we have gone right down to the pectoral fascia. I think the organizers, they realize that I am the director of this cancer hospital and are giving me additional time and not switching off the very decent on their part. So in this case, we have done a specimen mammography and removed the tumor and the surrounding microcalcification. I think that is a part of the axillary dissection, and one of the previous speakers very elegantly demonstrated how we do a lympha, and someone is also going to demonstrate how we do an S lympha procedure over the coming few days. So that there are two pillars. Once you do a wide excision of the tumor, there are two pillars that have to be eventually approximated with the help of sutures. Here the sutures, the three sutures are in place and they are being tied so that we can close the defect. You can do it at multiple levels. It's a better idea to do it at multiple levels and approximate the glandular and the facial tissues together so that you have a much better closure. And that is the final closure coming into place. I'll now come for the closure of the closure again in 2 layers, and that is the end result of this patient. And post-operatively also you see very good cosmetic results in many patients that we have operated. I think with that I come to the end of my short presentations on the Grisotti flap and the round block technique. Very simple, very elegant techniques that can be used by many of the surgical oncologists to gain access to various quadrants of the breast and retroareolar tumors. Thank you very much. I once again am very happy to be able to be speaking in front of Madam Prabha Yadav, one of the pioneers of, and you know, we have always looked, I mean, the entire audience has completely, without any debate, looked up to you as the real master of onco surgery, reconstructive onco surgery. And we are very thankful that you have been here today. Thank you.